Hello and welcome to this edition of Your Health, Your Wealth. I'm your host, Eddie Patton. And one of the things I love about doing a podcast is I get to interview a lot of great people about a lot of different topics. But today I just felt it's important for listeners to get to know me a little bit better. So I've invited my producer, former radio personality, and now the head of Speak Podcasting and innovator and leader in the industry of podcasting and social media innovation, and said, hey, I'm going to let him interview me, and so that I can answer some questions about what I do on a day-to-day basis, and particularly in the field of neurology and some of the conditions that I treat. And hopefully this will be insight into learning a little bit more about me and what drives me. So Freddie Cruz, the man behind the mission and the vision. How are you doing today?
Dr. Patton, thank you so much for welcoming me to your podcast. Every time we do one of these recordings, I find myself walking away with even more questions than I had going in. And I thought, what better way to have an episode with you than to ask some of the most common questions that people have around the internet and possibly in your practice. So let's dive into myasthenia gravis. It's something that I didn't even know existed prior to meeting you and producing for your show. So consider me a stand-in for every listener who's ever Googled symptoms at midnight. And we all know that Dr. Google is terrible.
Absolutely.
So let's get into it.
So myasthenia gravis is a neuromuscular condition, and it's primarily a muscle condition. And when you think about, even as a neurologist, I do treat conditions of the brain, spinal cord, but your nervous system extends from the brain, the spinal cord, all the way out into your muscles. And the end point is actually telling your muscles to go or work. And there you have your nerves. They don't plug into your muscles like plugs in light cord plugs into the wall, into the socket. There's a junction called a neuromuscular junction. And there are a lot of things that go on at this junction that tell the muscle how and when to work, how hard to contract, and so forth. So myasthenia gravis is a condition that affects the nerve-muscle junction. And in general, you usually build these what's called autoantibodies. So your body's trying to fight something else, a virus or an infection. But instead of creating these antibodies against this foreign agent, it creates antibodies against itself. And in a high percentage of cases, over 80% of myasthenia gravis, you have these antibodies that are created against this acetylcholine receptor, which is the main hormone, the main thing that goes across and tells the muscle to go. So it affects muscles, particularly muscles that you work a lot, things like breathing. So one of the things that can happen is that people can have problems breathing, your speech, your eyes. One of the first signs is usually what's called ptosis, where you have drooping of your eyelids. You can also have double vision because of eyelid weakness. So in general, if you have what's called fatigable weakness, meaning that you get weaker as the day goes on, you start to have weakness with doing activities, then you're fatiguing that neuromuscular junction. You're fatiguing those acetylcholine receptors. And that's one of the hallmarks or key things that I look for in this condition.
Yeah, so right off the bat, I do have a question. You said the body essentially attacks itself and it creates antibodies against its own receptors. And one of the telltale signs is fatigable weakness. You get weaker as the day goes on. What does that actually look like for somebody that's living with it? Like, what are the early visual signs that somebody might notice?
Yeah. So usually it's just double vision. It's not something that can cause blindness per se, but it's just that the muscles that control. So if I want to look to the right, there are a set of muscles in my right eye that have to move one way, and certain muscles in my left eye that have to move the other way. And they have to work together. And so what happens if one of those muscles is weak, then the eyes don't line up. And that's where you have the double vision. So it's not necessarily a problem with your actual eyesight, like a problem with the eyes or the part of the brain that controls the vision called the occipital lobe of the brain, but it is a problem with the muscles controlling the eyes that don't line up properly.
Okay, so it's not the actual vision that's going away, it's the muscles controlling the eye movement that aren't cooperating. Okay.
Yeah.
That's a really important distinction because I think a lot of people might write that off or assume it's something like a vision prescription issue. What about the more serious end of the spectrum? What happens when MG goes beyond the eyes?
You know, the thing about it is myasthenia gravis, its name is gravis for grave. Before steroids, the 1960s and so forth, there was a high morbidity and mortality from this disease. And that's because of these problems with swallowing. And a lot of times it's aspiration, where you're trying to eat something or drink something and it goes down the wrong pipe into your lungs, causes an infection, and people can die from this. We call this a myasthenic crisis, or with shortness or with problems breathing. So it's one of the things that we really look out for with myasthenia gravis. Now, with the new treatments that have come about, the morbidity and mortality is so much better with this disease, and people are not ended up a lot, in the hospital with what's called myasthenic crisis, different things like that. But definitely patients who have problems swallowing and breathing, I'm really paying attention to them a lot closer. I'm more aggressive about their treatment because I know that those symptoms can be the ones that cause the worst problems.
Wow, the name really does say it all, gravis, grave. And I think people hearing for the first time might feel a wave of panic when it comes to the disease, but you mentioned new treatments have significantly changed the picture. And I want to go there, but before we do, is this something people are born with? Is it genetic? What causes someone to just develop this?
There are some genetic myasthenic conditions, but they're very rare. They're very rare. Most people just get this, and we don't really know why, and that's the interesting thing about it. We see two peaks as far as age. So in women, the peak incident of when women usually get it is usually in their 30s to mid 40s. And then they have a smaller second peak in their 50s and 60s. For men, there's a small peak in the 30s and 40s, but the big peak for men is in the 50s and 60s. We don't know how this happens. Sometimes if you have other autoimmune diseases like lupus or different things like that, it can make you a little more prone to something like myasthenia gravis. There are also certain medications and treatments, checkpoint inhibitors, different things like that can make you more prone to this. But yeah, that's the interesting thing about the disease is that, when I look at my patients that I treat, it's a huge spectrum of ages and different sexes that come in.
Okay, that is really troublesome because I heard you say 30s, 40s, 50s, and 60s, males, females, so it can really hit at any stage of life. It seems like none of us are safe. That's both humbling and terrifying. So from a patient perspective, what does the early warning look like? So if somebody's listening right now and it's clicking for them, what's the go see a neurologist threshold?
Yeah. Well, the good thing about this is that it usually is gradual.
Gotcha.
And so if you have like acute weakness that starts all of a sudden, then that may be something different, like a stroke, and you should go to the emergency room immediately and get treated. This usually starts with ocular symptoms, ptosis of the eyes, double vision, and that can go on for a year or two before it actually goes into what's called generalization, or where you start having weakness in the muscles. So the good thing about it is that we have time to intervene if we catch it early on. But usually a lot of people wait. Even if they have mild symptoms, they don't recognize the symptoms, so they just kind of, I'm getting a little weak, maybe I'm getting older, or I'm deconditioned, or something like that, and they don't realize it, and so they don't come to me until, a year or two after the symptoms have started. We can still intervene, but certainly the earlier that you catch it, there's certainly, more that you can do. So for the most part, if you are having like a lot of weakness, meaning if I get up and walk for my usual distance of time, or like people who garden, they say, hey, getting up and down off the ground when I garden, all of a sudden I'm having trouble doing that after 15, 20 minutes, then that's when you want to talk to your doctor and possibly see a neurologist or neuromuscular specialist like myself.
And that really makes sense because the human tendency to just push through, it seems like a natural thing, especially when it comes and goes.
Oh, you'd be surprised the story that I hear. I mean,
Okay.
The human propensity to just deal with stuff medically, especially in today's world, there's a lot going on.
Oh, man.
I think sometimes we just, and this is an episodic disease, meaning that it's not constant. It's a fatigable disease. So once those acetylcholine receptors are all bound up, then you start having weakness. So you may wake up and you're fine, but it's like 4 or 5 o'clock. Now you start seeing double vision, getting weaker. So you take a nap, like, oh, let me sleep it off. And then you wake up and you're better because now the acetylcholine has restored. So it fluctuates. And I think that's the rough thing about this and why some people can go a long time without getting a diagnosis, because they just kind of blow off the symptoms.
You know, this reminds me of an organization I work with, the Lighthouse of Houston, which services the blind and low vision. There's a segment of their clients who went blind from diabetes. Several of them have talked about how they suddenly lost their vision while driving down the freeway. There's a story of a truck driver who was down the road and had to get navigated to the shoulder by his dispatch team, and that is frightening. So when somebody that has MG experiences double vision, what does that mean for them in terms of losing vision or going blind altogether? Is that even possible?
Yeah, no, that's a little bit different, or even a stroke where you usually can lose vision in one eye or the other. What I typically see here is, a lot of innovative things. Like I have some patients who literally will come in and they tape their eyelids up to drive. I have, I've seen all type of things like that. Some people wear a patch on one eye because, again, it's an alignment. So if I just patch one eye, then I can still see pretty good with the other eye. So those are usually the type of things that I see patients kind of doing these piecemeal things to try to get over or overcome the double vision.
Taping your eyelids to drive, that is resourceful and heartbreaking all at the same time. And it really speaks to how much people are going to tolerate before seeking help, right?
Yeah.
So let's talk about some of the other symptoms that might not be as obvious. What else can MG affect that people wouldn't immediately connect to a neuromuscular condition?
Yeah, so the other big one is, of course, shortness of breath. Your diaphragm is a muscle. That's the muscle that when we breathe in, your diaphragm contracts, and breathe out, it relaxes. So it's a muscle, and we sometimes forget that. And when the diaphragm becomes involved, then you can have like shortness of breath with walking short periods of time, or short distances rather. And so that's a big problem, particularly with myasthenic patients, because they just, they're constantly out of breath. And that's another one of these things that can lead to the myasthenic crisis and a lot of the morbidity and mortality. Some of the other symptoms, like I had one patient that I had to write a letter to her job explaining what this is, because she did a lot of sales and most of her job was working from home on the phone. Well, me talking, I'm using the muscles of my throat to open and close and so forth. So what happens when you have myasthenia is when you talk for long periods of time, your voice can become slurred. And so her company thought that she was doing drugs or drinking heavily while on the job. And she was at risk of being fired because, her drug tests, everything kept coming back clean, but her voice was becoming slurred as she kept talking to clients. So I had to write a letter and saying that, hey, this is what it is. This happens with myasthenia, is that the vocal cords fatigue and a person can have slurred speech. So she's not drinking, she's not on drugs. This is a medical condition that's causing this. And so there are little things like that that we often don't think about or take for granted. Just, you and I both podcast and can sit here and run our mouth for 30, 40 minutes, but people with myasthenia, after a few minutes, it fatigues and becomes very difficult. So those are some of the other smaller signs or symptoms that are sometimes overlooked.
That's wild, and also a perfect example of why awareness matters. You have a patient who nearly lost her job over a medical condition that nobody even recognized. And I mean, quite honestly, who would believe that if she's at home working on the phone, right? And you're not in the office and you can't see whether or not she's telling the truth. So before we land the plane, I want to end on something I know you're genuinely excited about. And you've talked about how far this disease has come since the 1960s. So why are you optimistic about the future of treating myasthenia gravis and some of the other conditions that you work with patients on in your practice? What's the thing that keeps you fired up?
Yeah, so the good thing about this, and I can't emphasize enough the fact that this disease prior to the 1960s and the steroid era had a very, very high morbidity mortality. Like, people died from this often. But now that does not happen as much. We've almost reversed things just because we really put a lot of emphasis into research and have good treatments for this condition. The original treatments, or what really started us down this road to where it became less of a grave disease, was steroids. Steroids is like a treatment that's an acute treatment. If someone is first starting this or having a crisis, you can give them steroids, IV steroids, or oral steroids. There are medications that work right at that nerve muscle junction called acetylcholinesterase inhibitors, like pyridostigmine, different things like that work very well. Then we moved into an era where we were using IV medications like IVIG, which helps to change the immune system. And now, in the past several years, we have at least 3 or 4 new classes, like whole classes of medication. And with each class, you have 2 or 3 medications. These are what's called FcRn medications, the complement inhibitors, and now B-cell therapy. So without going into a lot of detail, the point is that we have so many different ways now that we can treat patients. That what I often say is that treatment has become tailored now, meaning I can tailor the treatment to you. And the other thing, a lot of these older treatments like steroids and some of the immunomodulating, they had a lot of side effects, bad side effects. Steroids does wonders for a number of different diseases, but man, steroids can wreak havoc on your body, especially if you take them for long periods of time. Weight gain, just problems with diabetes. We talk about blood sugar, like it just wreaks havoc on the body. But with these new treatments, we're able to treat patients better. I can find what treatment works best for you and minimize those side effects. And again, the number of patients that I've even had to send to the hospital for this has drastically gone down over the past couple of years. On top of that, there's also a surgical procedure called a thymectomy. We think that the thymus gland is a little gland that sits like in your throat here. When we're children or babies, the thymus is what helps us develop our immune system, create these antibodies. But it should shrivel up kind of pretty much and go away because the immune system is taking over different other parts of the body. But what can happen is you can have inflammation in the thymus in an adult, or a thymoma, which is enlargement of the thymus, and it starts spitting out these bad antibodies. So what we found is that you can go in, do a thymectomy, and take out the thymus, and that helps you with recovery as well. So there are a lot of things with myasthenia gravis to be optimistic about. I love treating this condition because I have tools that I can use and just making people better. So it is a very exciting time when you talk about myasthenia gravis.
Love that. Well, Dr. Patton, this was great. Like I said, every time we come into this, I leave with more questions, and that's after getting a bunch of questions answered. And it really does make me feel like I'm leaving a masterclass in how to care for my brain and how we as a society can care for our brains, and simultaneously making me more aware of how much I don't know. So I think that's the best possible outcome. If you're listening and something in this conversation really resonated with you, please consider sharing it with somebody in your life. Dr. Patton, take us home.
Absolutely. Yeah, like I mentioned earlier, the good thing about this condition is that it can have a huge impact on your life, affecting everything from muscle weakness to double vision, breathing, swallowing, talking. But if you see the right physician, one who knows about all these new treatments, I mean, we're doing wonders and great things with this condition. So it's one of those things in medicine and in neurology. We're known for diagnosing a lot of things, but not being able to treat a lot of things. But this is one thing that I feel confident in saying, that we have great treatments there, a lot of different classes of medication. So I'm excited and optimistic about the future, and love seeing these patients so that we can intervene and make their life better. So thank you for joining us for this edition of Your Health, Your Wealth. Hopefully you learned more about myasthenia gravis, which is one of the conditions that I treat. If you enjoyed this episode, please sign in to the show, write a review, share it with friends and family, and tune in for future episodes of Your Health, Your Wealth.